it's like sending more guys into the Battle of the Somme. You're not going to get you're not going to get any more ground. You're just throwing more people into a system that doesn't work.
John Bell, who'll be a familiar voice and maybe even a face to many of the Today programme's listeners, was on the Today programme often during the pandemic. He's one of the most senior medics working in Britain, has advised successive governments, including ministers, during that pandemic, and worked on the Oxford AstraZeneca vaccine until recently Regis Professor of Medicine at Oxford University, and above all, John, a Canadian, which is the most wonderful thing of all, because it means we can talk about Canada until I was going to say the cows come home, but that's pretty inappropriate. But good to see you. How are you?
Yeah, very good. Thanks very much. Yeah, nice to see you both.
You've heard tell of the NHS's problems for quite a long time. Let's just go to the headline facts and some of the things that we know are coming out. Is the NHS underfunded, John?
So I think it is not underfunded, to be honest. I think we need to get better using the money that's in it. One of the things that happened is in this model of looking after sick people at the end of the stage of their disease is you build a lot of hospital capabilities and you put into place specialist care. So you got specialists in eyes and ears and noses and all the other bits. So you build up what is actually quite an impressive array of facilities for end-stage disease. And that's what the hospitals do. So that's kind of fine. And I think the conundrum that ERA will have to allude to is if you want to do anything but the old model, are you going to really take money away from those guys to give it to something else? And the answer is that'll be quite hard, because if you take money out of that, then, when granddad gets prostate cancer, he's not going to get treated properly. And people are going to go, hang on a minute. How does that work? So that is a fixed cost, and I don't think it's very flexible. The other bit, of course, is what's been going on in the community. And of course, in the community, the number of primary care doctors has not been increasing; it's been shrinking, unlike the acute sector. And they're really not able to cope, again, because of the same demographic change. Because a lot of the frail elderly, before they end up in hospital, they potted onto the GP 4 times, and then before you know it, they're swarmed. So the system hasn't really developed any demand management capabilities, which I think is one of the fundamental problems. Because if you just let it roll on and we continue to extend life expectancy, but we all accumulate all these diseases, we're stuffed, I think.
The traditional demand management technique in Britain was the waiting.
That's the waiting list.
So you basically,
exactly,
I mean, it's brutal, but this is what health economists... I remember learning this when I first made a film about health.
Exactly right.
Back in the 80s, you manage demand by making people wait so long, they either give up or crudely die.
No, it's completely right. I mean, it's an interesting challenge to run a single-payer, state-funded healthcare system in the modern world, because what historically we've always done is we've given people multiple mountain ranges to cross if they wanted to get to care. So they'd have to wait for the GP, then they'd find a and then there'd be a letter to the hospital. Somebody would lose the letter. They didn't fuss too much about that. By the end, you get an appointment, you go in, you see it. It would go on and on and on and on. And then in the end, somebody might do something. But now, because the burden of disease has increased so much because of that demographic change, that it's now reached a bit of a crisis point. So things are starting to fall over. And I think, so there are 2 models. Crank the handle faster, which is, I think, the model that many people would argue you need to do. My view is that's really hard, because as you throw more people in to crank the handle, the efficiency of the system just falls away. And it's true with all kinds of organizations. Big companies are very inefficient because they have too many people. How do you manage that workforce in a sensible way? So I've argued, and I'm quoted on this, and that is, let's train an extra 20,000 doctors. That was a plan of the last government. And I just said, well, it's like sending more guys into the Battle of the Somme. You're not going to get any more ground. You're just throwing more people into a system that doesn't work. And I do think my personal view is that is not the model. You've got to have changing roles. People have to do differently. We have to move things to the community, try and keep things out of hospital wherever we can. and use a whole range of innovations to do that. So,
well, in fairness to Wes Streeting, the health secretary, he's talked about shifting from prevention from cure to prevention, and moving from hospitals to communities. I want to talk about some of the specifics that Ara Darzi gets to. Just before we do that, John, you've mentioned twice now my favourite D word, which is demographics or demography, and I try basically to inveigle that into this podcast every single week because I'm obsessed with it. And it's really, really important for people listening to this to know that when we talked for years and years and years about an aging population, the key thing people need to understand is it's now in the coming decade that that's going to bite, and it bites particularly in this context, which is healthcare costs. And this is not about being anti-old people, it's not about any of that stuff, it's just a fact that a 60-year-old costs a bit more than a 50-year-old. A 70-year-old costs a lot more than a 60-year-old. An 80-year-old costs a hell of a lot more than a 70-year-old. And a 90-year-old costs a huge amount more than an 80-year-old. As you get older, your cost to the country, to the public purse, grows exponentially, and we're about to see a massive increase, which is a good thing because people are living longer, and it's fantastic news. But we're about to see a massive increase in the number of very old people, and with it, an exponential rise in costs. So if we've got this funding crisis now, the coming decade is going to
It's going to get worse for sure. You rightly describe exactly what's coming. There's going to be a wave because, of course, the baby boomers are all hitting this period, and they are going to come with their 4 statutory diseases by the time they're 80 because they've all got 4 diseases. It's all going to have to be managed. They're all going to need new hips. They're all going to need new joints, of one sort or another. They're all a lot of diabetes, a lot of the kind of chronic diseases. Now, on the flip side, though. And you will know this because I know this, and that is when I was a kid, everybody died at 65, and they usually had a coronary.
It's a wonderful thing. It's a wonderful thing. People spending time with their grandchildren.
Exactly. We've eliminated 70% of those early deaths, and people do have these chronic diseases, but we all know the people who are 80, 85 years old. They go out and they play golf. They go play bridge in the evenings. They have a social life. So there's a very positive side to this that I think people tend to lose because they go, oh, my God, demography is going to kill us. But, the truth is people are getting the benefits, and they are seeing their grandchildren for an extra 10 years. Terrific result.
I just want to push you a bit, John, on this. You can't crank the handle.
Yeah.
You can't just pour in more doctors. Because people might just think, well, hold on, there's a set level of demand. We know what the backlog is. So we just hire some more doctors. And yes, that might mean more bits of kit, scanners for cancer, for example, or modernised buildings. And then we get back to where we were, they would think, under the Blair government, which inherited quite a big problem when it came to backlogs and managed pretty much to clear it over a period. Why can't that be done?
Well, so there's an acute reason why it can't be done, and that is that in the midst of all the expansion of the workforce and activity in hospitals, we'd forgotten about capital expenditure. So there's a massive backlog in terms of hospitals, hospital beds. There are hospitals falling over all over the country, and somebody's going to have to fix that.
Can Wes Streeting get these reforms through?
I hope he can, actually. I
hope
genuinely
is a different thing. Hope is a different thing. And I like
what does bitter experience?
What's the evidence that he can? Because hope is a marvellous thing, and we all need it. But, it's become a staple of conversation about policy reform on these difficult subjects in this country. People talk about a blob, an establishment that gets in the way and all that. So maybe they think you're part of the blob. I don't know. I mean, you happen to have the prestige of being one of the most celebrated doctors in this country. But can reform of the NHS actually happen?
I think people in the NHS are going, oh, my God, we got to change this. And we've got patients who are saying, actually, a lot of patients say, look, they did a pretty good job on myself or my mother or my sister, but then there are lots of examples where they've actually done a terrible job. So that dissatisfaction is coming out in the polls. People are saying, actually, I love the NHS, but I'm now really not very happy with it. So I think the momentum to do something bold is there. It won't be without difficulties, because you never do something bold without difficulties. But I think it's never been better positioned for a big dramatic step, which they could take.